pleasure of moderating this session. And I will say, so one, I'll tell you a little bit about HealthTech for Medicaid in a hot second. But how many of you guys, one, know who HealthTech for Medicaid is? Couple, few, okay. Have you ever been to a HealthTech for Medicaid session anywhere, whether it be at JPM or in a community clinic or in a community center? Okay, great, a couple. So we have a couple of principles. One we've already broken. One is we try to honor people's time. So we try to start on time and end on time. We are 13 minutes late, so I'll at least acknowledge that we're late, which is not my favorite. But we will try to end on time and allow you to spend time together. The other thing is the way that this session today is going to work. As you probably know, this is a bit of a unique mashup, right? And we're all super excited for this. We want you to participate. And so these tables in the front, eventually each of these folks, as well as one other leader, will be sitting at for us to broker trust. And that's really the topic of discussion today, is how do we broker trust between investors and the safety net? And what are those myths? What do we know? What do we not know? Who do we know? Right? That's our goal today. We have a Slido. We'll do this. We'll have some interactivity. It would be great if you join the Slido. Just HealthTech for Medicaid for a reason. We use technology as much as we can from an enablement perspective. But you don't have to use Slido. You can also use any other mechanism you want to participate. Everyone got it? Can I move on? Church say amen? Okay, good. All right, who is HealthTech for Medicaid? So I mentioned briefly, my name is Adimika Arthur. I run a nonprofit called HealthTech for Medicaid. Pretty self-explanatory. We will be turning 6 years old in little less than a month. And we really are on a mission to radically change the pace of innovation in the most vulnerable populations, our underlooked communities and our overlooked populations. We do that as a convener. And so we do these sorts of convenings all over the country. Medicaid is done 56 different ways. So that is all the states, the District of Columbia, and then all the territories. And so Medicaid is a state and federal partnership. And it essentially is the largest insured population we have in this country. It's about 87 million people, was 95 million at the height of pandemic, so we have had a drop off, and we are in the midst of a Medicaid redetermination period. This is Medicaid, right? It is a investable population. I am biased, but you also have investors up here who will either say yay or nay that it isn't. And so these are just some statistics on the Medicaid population. But I'm going to stop talking and get these folks to talk. But before I do that, I want to talk a little bit about the safety net. How many people here identify as working in or committing your life to the safety net? I'd say the through line in my career has certainly been, if you were at the session earlier today, it was really impassioned when Kyu talked about his life, both in public and private side of the ecosystem, but with a mission alignment to the safety net. Just for those folks who are new, I want to make sure that people understand what the safety net is. There are safety net providers. Typically, the safety net is comprised of providers of healthcare that offer services regardless of people's ability to pay. These folks are limited to hospitals, clinics, mobile clinics, and other folks. We heard a little bit earlier about federally qualified health centers and community health centers. There's also public hospitals. Some people call them safety net hospitals, dish hospitals. And then there is a unique perspective around how some safety net providers get additional, new, or unique funding. And you heard Kyu earlier talk about Bureau of Primary Care funding and how that provides a true safety net, a knitting, right, of funding. But the other thing that's unique about the safety net is it typically has a role in public health, right? Ensuring that individuals get access to care. So just as frame, just so we all were on the same page coming in, we are going to have this panel here, and then we are going to get to these tables to do some deep diving work and networking. And as we do that, I will give a brief natural pause. Meera's going to do some slides. And those of you in the back in these chairs can move up to tables. I would just ask you to leave one chair open for these folks to get to a table. All right? We good? Okay, I'm used to like call and response or something, you know? Are we good? All right. Yeah. Okay, good. Okay, I'm gonna start, this is a unique panel, and it's bifurcated right now. I'm gonna start on this side with Rashad and have him introduce himself, tell you a little bit about what he does, and then we're gonna go all the way down to Dr. Michael Penn at the end. Okay? Wonderful. Start.
Hello, everyone. Glad to be here. And my name is Rashad Collins. I'm the Chief Executive Officer at Neighborcare Health in Seattle, Washington. We're a federally qualified health center, been in existence for over 50 years. We serve about over 60,000 people, providing comprehensive medical, dental, and behavioral health services to underserved communities, with a particular focus on serving the homeless population. We're the largest adult dental provider, and we also provide services to any and everyone regardless of ability to pay. So very important work, working in communities that are historically marginalized and systematically dealing with chronic conditions and many health disparities. And happy to be here and learn more about how our work can intersect with all of you.
Hi, good morning, everyone. I'm Julia Liou. I'm the Chief Executive Officer at Asian Health Services. We just turned 50 years old, started by UC Berkeley student activists to make sure that there's healthcare for underserved, particularly for immigrants and refugees. And we are a health center of about 500 staff. We serve a total of about 30,000 patients, 50,000 with managed care. And we also have dental, behavioral health, medical services, and we also stand up quite a bit of community programming that address the social drivers of health, whether it's food insecurity and nutrition, counseling, HIV, and we also do a lot of insurance eligibility counseling as well. So kind of a nonstop shop. And we serve in 3 cities throughout our county, but because we have all of our services in 14 languages, of which 12 are Asian languages, we actually get a lot of community members and patients who come from outside of our county because we have the culturally competent linguistic care. And so really looking forward to this panel and having this discussion and dialogue.
Thank you. I am Kyu Rhee, and I serve as the Chief Executive Officer of the National Association of Community Health Centers, also known as NACC. And so that is the group that represents all the health centers in the country. Health centers currently serve 1 in 10 people. That's based on 2023 data, over 32.5 million folks in over 16,000 sites, and with a workforce of about 310,000 plus. We have are about 1% to 2% of all healthcare spend in the US to serve that 10%. So estimated $55 billion worth of buying power in terms of our expenses to serve that 1 in 10. 50% of the people we serve are Medicaid, 11 to 12% are Medicare, 20% are commercial, and about 18% are uninsured. Because of that comment, we see everyone regardless of their ability to pay. Last point I'll make is I'm a primary care doc, so I started my career as an internal medicine and pediatrics physician with the National Health Service Corps Scholarship. And so I worked in community health centers in the District of Columbia and also in Maryland, and had the opportunity to work in the private sector as well at IBM and CVS Health.
Wonderful.
Good morning. It's great to be here with such a wonderful panel. I'm Liou Shapiro, managing partner of Seven Wire Ventures. We're focused on helping to create the type of double bottom line that we believe can exist in venture capital, doing well and doing good at the same time. We've been involved with HealthTech for Medicaid since its inception, and have a number of companies that we've invested in that are not only members of the organization, but are doing great work trying to extend reach of healthcare services into underserved populations.
Thanks, you have got a mic.
Good morning. Thank you, Adimika, for having us. I'm Meera Mani. I'm a physician. I'm an Indian-born immigrant to the US, and I am a partner at Town Hall Ventures. Prior to this, I spent a decade building a consulting practice working with state agencies, safety net providers, as well as health insurance plans. Town Hall's mission and mandate is a focus on innovation for underserved populations. So as we'll talk more, whether it's youth mental health, frail elderly, crisis care, maternal health, and so on. So very excited to have the conversation today.
Hi, everybody. Dan Gebremedhin. I'm a partner at Flare Capital. Flare Capital is a Boston-based early-stage health tech and services venture firm. We're investing out of our third fund, which is a $350 million fund. Most of our capital is fairly strategic capital. We raised most of our capital from about 30 different strategic corporations in healthcare, large payers, large provider systems, some pharma med device, and lab companies. And we're early stage investors, seed, Series A, Series B. My personal background, also a physician, practiced at the Mass General for about a decade, worked at the Harvard Pilgrim Health Plan for a couple of years as a medical director, focused on pop health analytics and general strategy before joining the Flare team when we launched the first fund back in 2015. Great to be here.
Hi, everyone. My name is Michael Penn, and I'm a founding partner of Health Equity Ventures. I wear a number of hats, and so later on today, you'll see me with my American Medical Association hat, but right now it's HEV. And we are an early stage investment fund, but also an advisory firm that focuses on bringing innovations to underserved populations. And I look forward to the discussion today.
All right. Are you guys excited? Okay. We're going to start. Oh, I'm going to go back. Sorry, Meera. And I'm not going to take your thunder. We're going to start with the obvious. How often is it that you see this sort of a composition on a panel? Pretty rare. So I think I would love to start with some myth busting, right? And maybe I'll start on the venture side of the house. Can you guys just explain from your perspective, and maybe we'll start down with you, Michael, to start. What is venture capital, or just the investing framework as well, from the sphere of impact investing all the way to private equity? What are their thoughts about the safety net? What is their knowledge about federally qualified health centers? So maybe we can just start there.
So I'll start with the knowledge part and say it's small but growing. And I think there is certainly, through the efforts of HealthTech for Medicaid and Liou and my colleagues, an increasing recognition that to really serve and transform healthcare for our country, we have to put dedicated focus on the safety net. There's just no other way around it. Now, what's different about Health Equity Ventures relative to a traditional fund is we are systems thinkers, and I began this journey thinking I wanted to raise a traditional fund, but what became clear to me is that there was a gap between the capital and the implementation of those solutions. These challenges, the structural issues that hold people back, structural racism, colonialism, the roots of capitalism, are systems problems. And if we're going to transform healthcare, we need people that travel in a lot of different spaces to connect the dots. And so that's what Health Equity Ventures is focused on, whether it's bringing foundations to the table, connecting foundations with health plans, connecting founders, diverse founders with health systems, et cetera.
Yeah, Adimika, we actually wrote an article on the topic, called Dispelling Myths in Medicaid Innovation. And I would say there's a few very pervasive myths, at least in the venture industry, and even private equity to a certain degree. Number one is that Medicaid plans, the Medicaid program, quote unquote, doesn't have any money. I think oftentimes we think about the rates that Medicaid plans pay to providers, and then the cost for a certain segment of the Medicaid population being kind of the lowest rung of kind of payment, reimbursement rates. And therefore, there's this perception that, Medicaid plans, Medicaid-focused providers are just not good customers. And I think that's not necessarily true. There's a pretty specific segmentation within the Medicaid plan. It's not a homogenous group of individuals. And if you just look at one specific slice of the population and then make generalizations, that's going to lead to, I think, a lot of misconceptions. I would say the other, big pervasive, I would say half-truth is maybe how I would describe it, is that Medicaid is just too complex. With which to start businesses, with which to invest in businesses. And again, from a high level, each state kind of has their own kind of flavor of Medicaid. And I would say that many entrepreneurs and many investors just think of that as too complex and a big barrier to scale. And again, I think there are some companies that have successfully navigated that, but I think you have to be very thoughtful. When you invest in Medicaid and at being an operator or an entrepreneur in the Medicaid space. And so I think when we're looking for companies that are operating in and around Medicaid, we're looking for people who understand the system. Mm-hmm. And again, are creating purpose-built solutions for certain portions of the population that generally have a common set of needs.
Great. Yeah.
I would just say that if we go back, so my town hall was founded by my partner, Andy Slavitt. He ran CMS, the federal agency for healthcare under President Obama. And when they founded the firm, it was a little bit more of a theory of the case in terms of investment in Medicaid. Investors were more focused on, as Dan was saying, higher reimbursement areas, right? And that progressively changed through the work of the companies that started that first vintage of innovation or first generation of innovation. And to now, right, I think where we sit today, if you think about just private sector and government programs, there's about $1 trillion worth of government program expenditure, not just Medicaid, but also Medicare Advantage, ACA, and CMMI, that's going to move into public-private partnerships. Andy will always say, I ran a $1 trillion agency with 6,000 employees. So this doesn't work just by delivery through public sector alone. You need public-private partnerships. So if that's going to be our status quo, I think my encouragement to this group, and I'm really glad you're here, is you have to decide how you're going to be a smart collaborator in this public-private partnership, right? And so if you're going to be smart, understand the economic motivations, the personal motivations of the counterparties, whether it's managed care, whether it's us, or whether it's anybody or the vendors, and ask all the questions. And I hope you ask many questions today so we can really, it's here whether you like it or not. And so, and it can be a force for good, but only if you make it a force for good.
So a lot of great comments by my colleagues on the panel. What I'd like to add is that part of what drives the motivation from a venture standpoint is always thinking about a bottom line return. And yet when you think about that return, is it only financial, or is there also a return that actually comes back to society? And part of where we set out with a focus, first and foremost, on all of us as consumers of healthcare was to understand what's the impact at an individual level. And so in the swim lanes that we invest in, when we think about underserved populations or seniors as examples, we oftentimes have to look at not just how well a company can do based on a business plan, doing financial analysis, but also what type of impact will this company have in terms of being able to bring solutions that improve access, reduce the cost of care, improve outcomes, and trying to find ways to help balance the level of returns that are being generated, because we've found through the work that we've done now for 25 plus years is that when you can align all those various elements, you can actually build very successful and meaningful companies. And so part of the myth busting that we have to do is to say, it's not just about investing purely for financial return, but it's also about the overall impact that a given investment might have.
All right, I'm going to start down here. Any myths you want to start busting?
I think,
or perceptions, even.
Yeah, I would say, and I appreciate calling out motivations, right? And I think, on our side of the house, there's definitely misconceptions about, what are the motivating factors for ventures to be in the space, in a social determinant space, in a specifically within organizations whose mission is to serve people, right? And so when you think about, as was mentioned, what the returns are, because for us, spending the majority of our time focused on community, focusing on, what our patients need, what our communities need, and we have to be very cautious about who we're partnering with and what the motivating factors are. And if the bottom line is going to be the primary driver, that puts us in a very cautious mode for who we want to get in partnership with. So for us, if the motivating factor is also socially as well as financially, because we understand the very complex reality of healthcare. We understand that in order for us to drive our mission, we also need the financial stability to do that. However, that also means that we have to partner better, we have to partner more efficiently, and we also have to make sure that there's the reciprocity within the partnerships that we're developing so that we're not doing damage to community.
Just to build on what Rashad is saying, I think that actually, venture capital, I don't know if we've ever really talked about it really that much in the sort of community health center world. I think Kyu, as the new CEO of our national association, is starting to bring that into the conversation. But I think we're really just like early stage learning. And I think, again, that sort of, perspective, when I, used to hear venture capitalism, it was like, oh, there's always a bottom line. So it's really heartening to hear that there are folks that are thinking about, okay, now we're really, really going to invest in sort of underserved populations. Because, as Rashad was saying, we're always sort of thinking about what is the return on investment for our community? Because our community has, been facing so many health disparities over history of decades. And so what does that look like? And not to be sort of, placed profits over, again, mission. So I think that really we're just kind of in that early stage of understanding what could be. And then how can we shift what the framework of ROI looks like if we're going to be a partner together?
I got this. So I think there's a myth that this side is mission, that side is margin only. Or this side is purpose, and that side is profits.
Or paycheck.
Yeah. The reality is this side doesn't work without margin or profits. We're called not-for-profit or nonprofit, but we can't deliver care in health centers without those margins and those investments of those profits back into the...
No margin, no mission.
No margin, no mission, yes. Now, and part of me sees this, having worked prior to this role, 13 years in the private sector, seeing a lot of purpose-driven profit work, a lot of margin-driven mission work. So I think that myth has to be broken, but it is not going to be easy. Because ultimately it comes down to trust brokering. And health centers are very relational. And many of the communities that represent, at least this side, health centers, have had a history of mistrust, had a history of being exploited, have suffered racism and discrimination, bias, have felt the impact of profit over purpose or that perception. And so, to me, there's two ingredients that are going to be very important for this. Time, because to me, the best measure of trust is, how long are you here for? Mm-hmm. If things go down, if the profits aren't as good, are you going to stay? Because in many cases, the for-profit world can make a quick decision based on a quarterly earning decision. And we don't get a choice on this side. We stay, and we keep fighting as health centers have for nearly 60 years. So time, and then those trust broker relationships where we know there are people who are gonna fight to stay in there, even in those tough times.
All right, I'm gonna ask one kind of final question of like what you guys wanna see as inspiration as we go into our table sessions, which allows for us to commingle and be together and start to actually dispel some of those myths, and for health center leaders to say, I met a venture capitalist, and for venture folks to say, oh my goodness, I learned a little bit about what a federally qualified health center does. And I think that's the first step in the building blocks of trust. I think it is really a trust brokering session. It's very rare for this sort of a panel to be on stage together. And we did this intentionally because we're going to leave this sort of momentum of you on one side and you on the other to actually all mingling together in tables. So what I'd love to know on this side of the house is a little bit, and I'm gonna alternate you as you guys come back to saying this, but it's like good choreography. I'm doing that Beyonce this morning. I want to know any case studies, any portfolio companies you're really interested in that are actually doing the work that you would like to highlight. So folks out here get an idea of what you're investing in. And over here, I want to know a little bit about, and you did have a little bit of this in the last panel. I have a question actually for the two of you and a different one for you, Kyu. But over here, I want you to talk about what innovations are you most excited about? What innovations do you need, right? In many cases, health centers could actually be the innovators. So you guys could have the product or service or delivery system yourselves, and these folks need to actually fund it, right? And then Kyu, I want to end with you talking about what we're trying to knit together with NACC and HealthTech for Medicaid and some of the work that we'd like to see in the next brick, right? If trust is that first brick, what do we see on the horizon as the next brick that we'd like to see to build this infrastructure? So I'm going to start back over here. Is that okay? And I'd love to hear a little bit of your thoughts. And then I'll go to you, Rashad, and then we'll go. You guys got the choreography now? You got the dance steps? Okay, good.
Let's see, left foot, right foot. So before I talk about a specific company, I just want to say what encourages me and where I think there's the greatest opportunity is to have the humility for investors to kind of come to the table and recognize that there's so much privilege that we have, right, including myself, and that you've got to leave that as much as possible at home and show up and actually be courageous enough to look at pain, the pain that people are experiencing. It's an entirely different process when you're motivated from that informed perspective.
I just want to make sure, I don't want to put you guys on the spot that you have to select one of your portfolio companies, because I know how challenging that could be. It's like you guys selecting your favorite health center of your system. I don't want either one of you guys to have to do that.
Let me off the hook. Thank you.
But I want you can give themes. You can give a specific company if you'd like to, but I don't want people to feel pressure to say this site is better than the other site or this language is more important.
All right, so I'll give a couple themes. So one is leveling the playing field in terms of equitable access and impact for digital health solutions. That's one. Another is a specific focus on mental health for the Medicaid population with creative solutions around business model. And then the last thing I will say is molecular diagnostics that disproportionately benefit underrepresented or marginalized communities and both improve outcomes and lower costs.
Wonderful, thank you. Hold on, wait. Dance step, come on, yep.
Right. So I would say, on the innovation side, because we get the privilege to be part of the healthcare delivery system, right? And so as the delivery system, when we think about social determinants in particular, because only a very small percentage of what we actually do within our clinics is truly providing what's actually needed for folks to improve their overall health, right? So many other factors are driving the continued health disparities that continue to plague our communities. And so for us, we think about how we can continue to bring services to people outside the four walls of our clinic, right? Telehealth was an opportunity that occurred during the pandemic and grew exponentially, but we need to take that up a notch into the next level, right? A large majority of community health centers are in rural communities, right? Where it's not just as simple to be on a bus line or to receive services very simplistically. And so our delivery system in terms of how to truly get what folks need to them is not as straightforward as it needs to be. So from an innovative standpoint, there are so many different opportunities for us to do that better. And conversations like this are so important because, as Julia mentioned before, we haven't had this type of engagement previously to truly think about how we can push innovations in ways that haven't been done before, but are continue to be mission aligned, but also are impactful and important to the bottom line.
Thank you, Dan.
Yeah, maybe one kind of macro concept just to level set, and then a couple of examples from our portfolio. This concept that venture investors only care about profits is come almost antithetical to the venture model. We've invested in over 50 companies, and I'm not proud to say it, but none of our companies are profitable. At the end of the day, what venture investors are doing is we're funding losses. We're funding losses for concepts, ideas, solutions that out of the gate are just not going to generate profits. They don't exist because the reimbursement system oftentimes has not allowed for them to be reimbursed. And it takes thoughtful, intrepid entrepreneurs, and again, risk-taking venture capitalists that want to invest in what we think the future will be. And so I just want to level set there. I mean, that might be different than like private equity firms, much later stage firms that are investing in existing profitable companies. And so that's just one thing that I just wanted to communicate. And again, a couple of examples. Adeze is the CEO of Kayaba Care, which is a high-risk maternity program providing thoughtful care navigation, risk management, risk stratification, doula care to high-risk maternity populations. Again, they have to figure out how do you tech-enable the solution to deliver that, and then you have to go out and find the reimbursement because it doesn't exist. Another really interesting company called Ounce Care is co-locating community health workers and care navigators in low-income housing projects. Again, something that does not exist, and you have to kind of fund the product creation, the solutioning in order to do that, and then you have to go out and find the reimbursement. And so that takes years, it takes millions of dollars, and it's venture investors who are kind of taking that risk. And I think Kyu, you made a really great point. The goal is for this to become a sustainable business, right? At some point, you have to be able to show a path to profitability, and sometimes these companies kind of cross the chasm and get there, but oftentimes large established, payers, large provider systems, large technology companies see the promise and then will acquire these companies. That's kind of the path of venture stage investments.
And you guys invest in people, and Adeze's here, so I want you to stand quickly. Stand, because she's unique. And I want you to know that we have individuals who worked in government. She worked in the OMB. She also deeply knows private equity and wrote an incredible article dispelling the myths that private equity is not just raping and pillaging communities. So another great example. We don't want these to only be our unicorns, right? But that's what we get to have at our tables and discussion today is incredible, would you say trepidatious? And fearless, fortuitous entrepreneurs who are doing this incredible work. Julia?
I just want to say it's really great to hear all the myth busters. I think it's very helpful to hear. And, I think that as community health centers and, typical healthcare systems overall too, we experience so many pain points. And so I think one of the greatest pain points that, many of our health centers are experiencing around workforce and just the burnout from our providers, compassion fatigue. And so anything to do, any innovations that can really reduce that burden for our physicians and for many of our providers, I think is an innovation that I would be very excited about. I know there's a lot that's going on in terms of AI scribing, but I think that the barriers that we face is that it's not in many languages. And, we serve, a population that has 12 different languages. And so it's really challenging. So we can only go so far. And I think the investment opportunities are there because, frankly, there's not infrastructure within our health centers now because we're always responding to the community needs. We're always really tied down to figuring out the day-to-day. but there needs to be room, and there needs to be creation of room investments to create the infrastructure so that we can actually test these things out, that we could do some PDSAs to actually see if there's applications that actually work. Does it really reduce the workflow, for our physicians? And we have to test that out. And I think that the opportunity to do that is there. And if there is some partnership opportunities to do that, that's what we would be very excited about. So again, looking forward to the conversation at the tables.
All right, as any good choreographer would do, I'm going to change up the dance steps, right? Because we're going to do a double on this side and then this one, all right? So just want to make sure you got the steps down.
I'm ready.
Meera.
All right. I think I'd like to describe a collaboration that my firm did with Kaiser Permanente. Kaiser, as you know, is the largest integrated care delivery organization in California and nationally. We partnered with them to launch a new company called Habitat Health. It is in the PACE program of all-inclusive care for the elderly. I'm going to give you this example so you just see the puts and takes in a collaboration and, how it came together, because it might inform the thinking and the table discussion. So Kaiser has never done anything like this before with a venture firm. As you know, they are a large nonprofit, deeply mission-oriented organization, but they saw the mission in PACE. So PACE is for individuals who are eligible for nursing home level of care, but it provides community-based services, right? It takes your Medicare, it's mostly for dual eligible beneficiaries, Medicare and Medicaid. The average beneficiary is 78 years old, on 5 medications, and really needs help with activities of needs significant help with activities of daily living, right? So the Kaiser docs, who are among the most mission-aligned you'd find anywhere, knew that, could see those patients in their panels that needed a better solution for home-based care, for social services, for transportation, for socialization, but they didn't have anything to offer them, right? So, and we on our end were motivated by this program because, for us, the numbers are clear, right? Like there's very clear, unambiguous performance and cost relative to benchmarks. 95% of families and beneficiaries would recommend PACE to someone else, would recommend PACE to a friend, right? Very, very strong referral and incredible provider scores, right? So for us, the value to society and to families was very, very clear. Call that customer centricity if you want, customer and provider centricity. And we knew that with certain financial approaches, it could also generate the returns that we're obligated to provide our investors, many of whom are large healthcare institutions. So, intent on both sides, very clear alignment on what you want to put on behalf of members and families. 18 months of work to really hash through, build the trust through a series of steps. Through which both us and Kaiser invested into this business, hired a management team, governed the company jointly with Kaiser representatives and town hall representatives. So I say that to say where and we see, that's just one example. We see so many such examples that are possible with that kind of collaboration between innovators, strategic, healthcare institutions and investors. So. Great.
So I'll do the two-step here. So part of what drives interest in healthcare as a sector is finding ways to use technology to address some of the challenges that exist. And we have a number of companies that are doing work addressing certain specific needs, oftentimes in collaboration with a number of the health systems and other providers that are working in the communities to deliver care. One of those organizations that's doing work along those lines is called Payzen. They provide zero-interest financing to help individuals who can't afford their care. And they'll do this across the board for any individual who presents for care at a given hospital, partner of theirs, partners like Common Spirit. And what they found through their research is that many individuals are deferring care because they can't afford care. And what we're finding is that if you give individuals the opportunity to know that they can still get care, but they have the opportunity to pay off whatever it is their out-of-pocket expenses over a long period of time, structured in a way that meets their needs, so that if all they can afford is $10 to $20 a paycheck, that they're willing to participate in programs like that and still be able to access the care, as opposed to saying, this is just out of reach for me and I can't afford it. Another company talking about all the social determinants challenges that exist, called Ground Game Health, is actually on the ground connecting individuals in different communities with the resources that they need. Do they have a safe place to go home to after they're treated? Do they have electricity? How are they doing with regard to food security? And they're not only linking individuals to these services, but they're making sure that there's a follow-up and that there's results that are coming back to the federally qualified health center to know that those individuals are getting access to the services that are improving their condition. And we have a number of others that I could go into, but you're all going to want to have lunch at some point today, so we'll bounce back to Kyu and let him address the questions that Adimika posed.
All right.
There's one myth I want to just bust. I believe strongly that health centers are the most innovative part of the health system. I think building trust in communities, finding ways to do things with limited resources to deliver that extraordinary high quality, comprehensive, integrated primary care with the resources we have, the pay inequities we face, the challenges we face, there's no better investment, in my view, than community health centers, and there's no better entity that innovates than community health centers. I think in many ways our innovation has been focused on policy innovations. Much of the efforts that support health centers are based on efforts that have been in terms of advocacy for bipartisan, bicameral support in state capitals, Capitol Hill. And that is why the health center movement has this quilt of resources over nearly 60 years. I do worry, candidly, that the private sector, the for-profit sector, doesn't fully understand and value and appreciate the innovations that we have, and to the point where we would own the IP, or that we would have more than a transactional role. I'll just use the example of PACE. It was just referenced. Kaiser. I love Kaiser. Kaiser's a great nonprofit. I agree that Kaiser should be one of the partners of choice. Ultimed, San Ysidro. I've been across the nation now in 40 states. The PACEs that health centers have are pretty extraordinary. Agreed. And they're just an extension of the work they already do in those communities for 40, 50, 60 years. And so I think we're so used to at events like this to focus at these industrial-sized corporate partners as our partners of choice. And I think we almost miss out on the fact that so many of these extraordinary innovators are right there in the community, but often not viewed or valued as they could or should be.
All right, we're gonna get ready very soon, okay? This is your pre-warning for your own dance steps, to have folks move up to tables. But before we do that, so I'll just tell you, how did HealthTech for Medicaid get into this space, right? We are a convener, right? So we bring together payers, providers, policymakers, entrepreneurs, investors, advocates. But we center all of our work on kind of the equitable and inclusive design of products, services, delivery systems, and capital markets for that narrative change that we've been talking about today. And I'm an epidemiologist personally. Was very active in the first 1115 waiver in 2005 in the state of California, which is how I got the moniker Madam Medicaid. That in turn, that $180 million of federal funding that got split between 10 counties in California got me to turn into a hospital leader. So I ran hospitals for 15 years. And I got frustrated that I could not really save the lives of anyone else or talk about innovation or technology or enablement, right, beyond 100 miles from the front door of where I served, right? I also ran three federally qualified health centers in my time. So I'm a unique individual. And HealthTech for Medicaid, Liou has been here from the very, 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 very beginning, right? Started as, is there any companies that want to invest in Medicaid, right? And it started with a small investment, a planning grant that the California Healthcare Foundation funded, and 35 companies that we could find across the country who actually said, Medicaid, sure, why not, right? And, you know, I thought I would do this for like a year. I never got a maternity leave, so maybe 2 years. I have 2 children, 2 years. And that ended up, you know, at year 5, HealthTech for Medicaid's about to turn 6 in just a few weeks, but at year 5, I was asked, you know, what's next? What haven't you done? What do you want to accomplish? And what we realized was we had this venture council that actually started. Many of the folks on this stage are a part of our venture council, where we have about 40 of the top venture firms that actually invest in Medicaid. But we weren't really moving the needle. And so I took a year out of my life and learned how to be a venture capitalist. And I did that education to make sure one, could communicate and understand what this side of the table was doing, but also to begin this trust brokering exercise on this side of the table. And so this is a pretty pivotal time. We started something called Venture for Medicaid, which really our venture council built up, which is how can we educate investors in understanding Medicaid, not just Medicaid as a name, but the people, the stories, the family members, the community behind and underneath who is served by the largest insured population in this country. And I say that because I think as we turn 6 years old in this upcoming year, and the safety net movement turns 60, we have to move beyond not talking to each other at these tables. That's why we're going to be doing this. So there'll be a lot more of this sort of work moving ahead, but I wanted to just give frame on why we're here.
Adimika, can I give...
Please, yeah.
So one of the things we did not yet cover, but Dan alluded to, is that most companies fail. And failure in the context of the safety net is not acceptable. So the other rationale behind this dialogue is that you have to build together, right, through a trusted relationship, plan for outcomes that are sustainable. The business model may or may not be, but the outcomes and the care delivery and the service has to be. So that's a really, really important point, and I think I just want to make sure that we...
I'll jump on that too. I think the comment was made.
Do you want to actually go into the slides too that you have?
Oh, was I going to go do that anyway? I would say that, you know, let's go through this and I'll come back around, right? So because many of us have lived in different worlds, I, before being a quote-unquote investor in the Medicaid world and as a physician, the number one question at my dinner table with my friends, especially from med school, is, well, break it down for me. What exactly do you do, and how do we be smart collaborators? I hear a lot about investors and private equity. Break it down. What is it? What do I need to know, right? So we started to put some thoughts together, and at the most macro level, right, there's a few things you can do, and it really depends on what you're trying to build, and you know, what is that patient outcome or member outcome, right? So in its simplest form, I'm sure many of you are approached by innovators, right? I mean, and put venture capital aside, right? Like, you've been approached by electronic health record companies. You've been approached by care management companies. How do you evaluate them? How do you evaluate any private sector partner that wants to do something for your institution, right? So there is the simplest form is a contract, as simple as you like, for services rendered, fixed fee for technology, or value-oriented if you want to or no money changing hands. A number of our companies have not even contract. It's a pure referral relationship where the FQ or the institution will say, look, we can't take care of these people. We're not kitted to take care of these people. But we want to make sure that we can responsibly hand them to someone who will commit to us that they would provide impeccable care and will give us the information back on what was provided to that member and their family, so that we could take care of them, right? So that in its, you know, even to the left of contract is a just, you know, serve as an extension in the events that the institution can't provide those services. The second format is co-invest, right? So the idea there would be what we did with Kaiser in the PACE instance, right? Now, there may be criticism of, oh, well, that's an industrial scale partner. Well, I would be glad to partner with any institution that can commit $17 million to put one single PACE center into the ground and has the fortitude to spend 2 years to in licenses, in approvals in order to get that off the ground, right? So it doesn't need, not everything is PACE. PACE requires a lot of money. And one of the reasons it hasn't scaled is because we need to put more, so in some places you need more centers in the ground. So that's one part, but there are a lot of ways to invest alongside, especially if you said, look, this is a solution, a platform that I want to partner with, and I would like to invest in the company so that, yes, I am a customer, but when the company appreciates in value, when they turn profitable, like Dan said, I have the and/or if they were to either go public or acquire, I would also capture some financial return for my institution, right? So that's certainly one alternative. Those investments can range from tens of thousands or hundreds of thousands into the millions, right? Depending on the level of interest in that. Co-build is a third framework where you are essentially an anchor for co-building and innovation. This is where I think there's a lot of, here the single most important thing I would understand in addition to the financial variables and the economic and personal motivations is the IP, which was referred to earlier, right? Really having a clear sense of who has the IP, right? I think my colleagues will agree with me. It's often healthcare institutions say, well, you can't partner with any of my competitors, right? And that's a very reasonable position to take, but you have to understand, like, you don't say that to your EHR company, right? You say, you have guardrails, right? And you say, what's mine is mine. You build the IP with our work, and we need to get attribution, credit, financial, and otherwise, totally. And or you may even say, well, not in my catchment area, but you could partner elsewhere, right? But I think working that out early so that it doesn't become the elephant in the room would be one of the more important things to determine. And then I think co-design, right? That one is more of a, we need something, you're building in this space, will give you the benefit of, the pain points that we experience so that what you build will be something that we can use, and because it meets, are we the health center or the health system, and that meets our needs. So those are 4 forms, and I'd invite, you guys do a lot of this, so if there's things that people want to share.
I think we're going to skip the other 2 slides and just keep them as a part of education as we move along in this journey together, because I do want to give people time to get up, come to the front 12 tables. These individuals, as well as Dr. Ivor Horn, who's over there in the corner. So you'll go to that table if you want to sit with her. We're going to actually go to, these are the table leaders, and then I'll go back to the Slido so folks can participate. So this is the point in which I want you to stand up and disperse in the room. If you came with a bunch of people and you're sitting with your homies, now's the time to break up, just so you all can learn and develop and grow. And it's also for those of you guys who are going to get lunch early and don't want to sit at a table, you can exit.